On an individual patient level, that relationship holds, such that if a woman has a pathologic complete response, she is more likely to do well than someone who doesn't. But what we have failed to show, and we failed to show this pretty consistently, there are very few studies that would contradict this point of view. What we have failed to show is that if you compare regimen A and regimen B, and if in regimen A the pathologic complete response is higher, that has not translated into an improvement for that regimen in terms of disease-free survival. And it's probably more complicated than I can try to explain at the moment, but suffice it to say that it all depends on whether the patients who are now having a pathologic complete response who wouldn't previously, with, for example, the addition of carboplatin, are those patients who would have done well anyway, or are they the patients who really had refractory disease? If they're the patients who just simply didn't quite have a pathologic complete response but would have done well anyway, then improving that pathologic complete response won't help. If they're the patients with truly resistant disease and we convert that resistant disease to sensitive disease, then it would make a difference. And I think the unfortunate part of all of this is that most of our therapies seem to deepen the response, meaning it simply improves upon what is already a good response in some patients and doesn't necessarily convert someone who wouldn't have responded into someone who would have responded. And I hope that's clear. It's really, I think it's a complicated concept.